All right, it looks like we've got a really healthy quorum of attendees. So welcome very much, everyone. Good day. Excited to have you here with this robust panel that we've assembled to help us talk through and explore the differences between hospital-led primary care and independent advanced primary care. Um, if you've signed up for this, that must be a topic that's on your minds, and we look forward to exploring the pros and cons of both, share some experiences, share some data that you might find useful, and then hope that we can continue to be a resource, especially as we transition into being able to answer your questions, both live as well as if you'd like to enter them into the chat or the Q&A function on this Zoom call. But before we begin, let me go ahead and start with introductions. I'll start with myself. I'm Nirav Vakharia. I'm a primary care physician still in practice, and I also get the privilege of serving as the Chief Health Officer here at Marathon Health, where for me, it's the job of a lifetime because I get the opportunity to take something I deeply care about, which is making sure people have access to the right type of primary care and scale it across the country with the benefit of great teammates who are very mission driven and clients who really understand the value of providing this service to their employees, their union members, and dependents. But I'm really just your cruise director for today. The real talent is the assembled panel that we have. And I'm going to go ahead and start with asking each of them to introduce themselves. So Dr. Matt Kaiser, do you mind going first?
Yeah, good afternoon, everyone. I am Matt Kaiser. I'm the Assistant Superintendent for Human Resources for Washington Township Schools, which is a school district here in the Midwest with about 11,000 students and 1,700 staff, depending on the day. And we have had a health and wellness center in the district for roughly about 10 years. For the first 6 or 7, it was a hospital-led, and now an independent.
Thanks, Matt. Welcome. Dr. Natasha Parekh.
Hi, everybody. My name is Natasha Parekh. I am also a primary care physician. I'm a general internist, and I am the National Medical Director of the West and Clinical Vice President here at Marathon Health. My role with Marathon is to work with our teams and just ensure that we're set up for kind of success in providing high quality clinical care on the ground. I think just one relevant piece of my history is that I was born and raised in hospital-based primary care. So all of my roles previous to Marathon Health have been with hospital-based systems and hospital-based primary care clinics. This is my first role with kind of non-hospital-based advanced primary care, and it has been a breath of fresh air. And to be able to really compare and contrast and see kind of the benefits and the value of our model has been just incredible for me. And so I'm excited to share some of that with you today.
Great. And Dr. Doug Sumner.
Hello, everyone. My name is Doug Sumner, and I'm fortunate to serve as the Vice President of Education Affairs at Marathon Health. I've been with Marathon Health for just over 4.5 years, prior to which I spent my entire professional career in public education, where I was a classroom teacher, a principal, an associate superintendent for human resources, and also a superintendent. I'm also a former Marathon Health client as we opened our first on-site health center in the Shawnee Mission School District in 2016. And I tell people all the time without hesitation, in decades of service to public education, the very best thing we ever did for our staff was open our on-site health center. So grateful for the opportunity to be with you today and looking forward to the discussion.
Great. So we have a mix of experiences here. We've got folks who were on the hospital side, and I'm one of those as well, who have moved over to being on the right side of history, if you ask us. We've got folks who were clients and now are employees. So we look forward to really unlocking some of the wisdom that sits within this group for your benefit today. And again, to make sure that we answer your questions. So just as a reminder, we'll have time at the end for Q&A where you can ask questions live. In addition, please feel free to start entering them into the chat as they occur to you or into the Q&A function. But let's just talk a little bit about what we hope, 53 minutes from now, you feel like you've learned. First will be, is there even value? What is the purpose? Why take on the work of even trying to improve access to primary care for your employees and dependents, if not to go to the next step and make sure that you provide that access directly through an on-site or near-site health center. So we're going to explore that a little bit because we know there may be different levels of interest or experience or background in that. And then we're going to really work to explore the differences between the two models that sort of make up our title today. As Natasha and I have both worked in hospital-based primary care, we can give you a little bit of what's behind the curtain there, in addition to what's different if you choose to go with an advanced primary care organization like ours or others. And then we want to make sure you understand kind of what are you solving for here as you do this? What kind of results should you be expecting across a variety of things like the experience of your population as they engage in care, their productivity, your ability to retain them because you're offering an enhanced benefit, the impact to your days away from work, the impact on the bottom line of your medical spend. There's all sorts of things that we can start to dig into and understand the things you should expect as you engage on this journey. And then, of course, like I said, we want to answer your questions. So with that, speaking of questions, we want to ask one to kick things off. So if we can go ahead and launch the first Zoom poll, it should be pretty self-explanatory for you. A window should have popped up. And please go ahead and read the question and enter your response. All right, let's go ahead and see what the poll results are. Okay, so we have quite a learned crowd here with the majority of folks having some experience in one or the other or both, and then about a third of folks who are new to this. So we look forward to addressing the needs of this entire group. But let's kick in with our panel discussion and start to get some thoughts out there with just that basic question I started with. Why even bother? With everything you've got on your plates, Matt and Doug in your former life, like why even bother doing this? And I'm going to ask you to take that in two parts. Why bother increasing access to primary care, period? And then if you agree with that one, if you can build the case for that, why take on the work and the expense of doing it yourselves through some sort of on-site or near-site health center? Matt, would you like to start?
Yeah, I think when we initially explored this, a lot of it was centered around this idea of building wellness and community among our staff and giving them an opportunity to make sure that they felt like their employer was genuinely invested in that, in not only their professional lives, but also their personal lives. We knew that there would be some added, cost benefit, reducing some of our visits to ERs and urgent cares on our plan, but that wasn't really the primary focus. It was really about trying to build a community. I always talk about it. It's like we have our own town doctor that knows everybody and everybody knows that healthcare provider. And then we have this added benefit of we can tell that town doctor when to be open so that they can meet the times as educators. Obviously, we have a wide variety of different school start times and when our employees can access that, and we can set that up for them. Probably the biggest aspect that we, or at least I, didn't anticipate was the productivity value. I'll give an example. We had a custodian who had an injury outside of work that activated some comorbidities, and doctor wanted his vitals to be taken literally on a daily basis before, reporting to work. Traditionally for us, that probably would have resulted in 6-ish weeks of that person not being able to report to work and us having to pay a marked amount to cover that person while they were out. And instead, we were able to set up that with an on-site health and wellness center that was right next door to where he reported to work. He reported to the health and wellness center. Those vitals were taken. He was able to report to work on a consistent basis. And we ended up having a person who was dedicated and committed to the space, who was able to remain in there rather than being off work for 6 to 8 weeks. And then actually unsolicited, someone who works in my office walked in, I promise, to my office 2 days ago and said, I just want to tell you how much I appreciate us having that marathon on site. She wasn't feeling well the night before. She got online. She had an appointment at 8 in the morning, was able to meet and be here at work at her traditional time. I think generally, from what she said to me, that probably would have resulted in a day of missed work if we didn't have that in place. So really for us, it's about building that culture of wellness and going beyond just acute care. And also, we've had this added productivity benefit that's just been great for us.
Thanks, Matt. So I heard themes around building community, the convenience of it, and how that helps with productivity. And I imagine you also saw greater attachment of your employees to the school system and hopefully retention followed with that. Those are fantastic, wonderful things that we know people are starving for. Doug, you undertook the same journey. Why go through the effort?
I would say this as somebody who's been a former client and now as someone who supports our existing partners. I think an organization should do this because A, your people really need it, and B, because the organizations that do this benefit in, as Matt said, in incredible ways, financially and beyond. Every organization on the call today has a mission they're trying to achieve. And regardless of what resources you may have available to you within your organization, the one resource that best positions you to achieve your mission are your people. And right now, the American workforce is struggling at unprecedented levels with their health and with healthcare. And it's really not just the employees that are struggling. Most organizations are paying more and getting less when it comes to healthcare benefits. We also know that there's a strong and direct link between an individual's health and their job satisfaction. And if we push that 2 steps further, we also know that job satisfaction has a direct link to things like productivity, retention, and those, of course, are things that are so important to any organization. I think for us, it came down to a lot of the things that Matt said, that our people were so grateful that we were willing to do something that we didn't have to do, that communicated to them that we cared as much about who they are as we did what they did for us. It's a simple fact. Healthier employees are higher performers, and healthier employees cost the organizations that employ them significantly less. So in my experience, it was the ultimate everybody wins scenario.
So before I bring in Natasha, Matt and Doug, I'd like to ask you to take it one step further. Some might say the things you described are nice to have. And these days, we may not be able to afford nice to have.
Yeah.
Can you tell us from your perspective, as those who had the courage to take this risk, what made it a must-have instead of a nice-to-have?
Well, the first thing that jumps to mind is I would believe that any organization, your highest financial investment is in the people you employ, the salaries, the benefits, and everything else. So we have to find new and better ways to take care of those folks. They're your number one investment. They're your only path to success. And so for me, this quickly became not a nice to have. It became essential because of the impact it had on those things I just mentioned. Our people were happier, they're healthier, they were performing at higher levels, they were staying with our organization longer, they were showing up to work in a more prepared sense to do their job, to perform their role. We have to understand that for decades and decades, we provided a pathway to care. We provided health insurance benefits. So, hey, if you want to seek care, here's a pathway for you to do that. We have found that now it's time to provide the actual care, that it is a difference maker in the lives of those you employ. And as a result, it is a difference maker in the level of commitment and performance they have with your organization. And here's the other thing, the cost and the implementation is not a lift. There of course are costs, but in our organization and in every single partner that I have oversight with now at Marathon Health, the financial return on investment is beyond 1-to-1. So this is a solution that pays for itself. It takes time. You have to develop your level of engagement. You have to change the behaviors that lead people to seek the care that is difference making. But this is not a lift. I think so many people, I know I was one of them. I was so intimidated by the possibility of doing something so different. It was so difficult for me to help our board understand why we were doing this because it was something that a lot of people weren't doing at the time. Um, I think also people saw it, as you said, as this kind of fluff benefit for the grown-ups in a school system where we're supposed to be focused on kids. But we quickly helped our board understand that the best thing you can do for kids every day is surround them with happy, healthy, high-performing adults. And our health center helped us achieve that.
Yeah, I would say along those lines that, yeah, the accountability measures that we have from our community, from the state, from all sources, they're not going to move and they're not going to change. And for us, we know that the high quality individual who's in the classroom or in that space is the number one determiner of how effective we are as an organization. And so when you look at things that you can do to help support that, I think there were few things for us that we felt like that we could put in place that would impact that universally across the system, right? Not an intervention in one grade level, not an intervention at one school, but across our entire system, we could get better by putting that piece in place and making sure that our people were there and in their jobs and ready to help and support our kids every day. And so while I understand that idea of that it's a cost, for us, the cost versus impact, as we looked at it, was a really easy decision.
Thank you. Thanks to you both. So, Natasha, Doug made a statement earlier that people need this. They need access to advanced primary care. Um, when you think of your perspective as a leader of providers who deliver this, as well as a provider yourself of this concept of advanced primary care, can you give us a little bit more detail on why people need it and maybe what you're seeing as to why they're not getting it elsewhere?
Yeah, sure. So I think when I think about the experience we're able to provide, right, really comprehensive kind of a primary care experience, especially with our organization where we have, on-site medications and labs, we can have on-site interdisciplinary services, et cetera. I think about, is that a nice to have or need to have? I think once you experience the model and once you actually live through it, it really does, I think, transition and transform for our patients from, wow, this is really nice to this is actually, everybody should have it. Everybody should have access to kind of a model that provides kind of comprehensive, all-in-one kind of primary care services in terms of not just patient experience, but health outcomes. I think the ability for an employer to really impact the health outcomes of their populations through an on-site clinic is just an incredible opportunity. And I think that's where it becomes a need in the sense that I think the opportunity to be able to really understand and know your population and understand their particular health needs and to be able to deliver on that through an on-site health center is just, it's so tremendously valuable. I think just to give you some examples, we've had some clients who have shared, I think our population is really kind of struggling with mental health issues right now, and education would be really helpful. The ability for an on-site center to then respond to that to say, okay, well, let's provide mental health services, or let's have more education. We can do lunch and learns with your employees. We can have kind of educational programs focused on this. It's really hard to do that on the outside world, right? Where you have kind of your employees kind of seeing community-based primary care providers across kind of your areas, really hard to kind of really move the needle as you identify a specific need for your population and to be able to meet that. So I think kind of the need there becomes, I think, this need to meet your employees' needs through kind of through kind of an advanced primary care solution.
Thanks, Natasha. And I'll just put a couple of statistics to this because, for me, a fun Saturday night is getting a journal out and learning about the status of primary care in this country. But today, in this country, almost 30% of adults are reporting not having sufficient access to primary care, and 13% of kids. And the sum total of that number is almost 90 million people in this country who don't have the access that they need. And I'm sure those people exist in every community represented on this call today. When they do get in, average time to first appointment is 37 days. And that's on a good end. They can spread out up to 4 or 5 months. And I bet if I asked every person on this call, do you or a loved one ever have trouble getting into your primary care? I bet every hand would go up. We also know that there's only one health service in the history of this country that has been proven to improve population level outcomes, reduce utilization of hospital services, reduce overall cost of care, and actually increase longevity for a community. And that only health service is primary care. So my public service announcement today, and I think everyone on our panel would agree, do whatever you can to increase access to primary care for your population. That is just the great work to be done by anyone who can influence benefits. And now let's talk about opportunities on how you do that. So we've really wanted to now sort of bring our focus to there are multiple options for you if you're going to take charge of this problem. And one of those options is you can go with trying to engage with the local hospital system that typically offers analogous types of services, or you can go with a dedicated provider of advanced primary care. Let me start with Doug and Matt. You guys both chose to go the route of advanced primary care and not through your local hospital systems. First, explain to us why. What did you see as the differences, and why did you choose to go with an APC provider?
For me, I think I would start by saying this, right, is that I think it's important that I share that I believe everybody responsible for providing care has great intentions. But I also believe that our independent model better positions us to really focus on the advanced primary care and directly attack the obstacles that lead many people to focus more on treating illness rather than establishing and maintaining wellness. And I think that's the difference between what we saw in the hospital-led models and what we saw with an independent advanced primary care model, is that we wanted to separate from this routine of just treating illness over and over again, and instead focus on a model that established wellness and maintained that wellness. And I think to do that, the thing that we see in the more independent model is that it's built better to address a lot of the obstacles we see to advanced primary care. And we've already talked about one of them, and that's access, right? So the thing that Marathon Health has done an exceptional job at is bringing care to a more convenient location. And I know a lot of models do that. But we're also looking not just as access as where the health center is. Access is also when. So when can you access that care? And so for us, it's working with our partners to establish hours of operations that align with the needs of their workforce: early morning hours, evening hours, weekend hours. And we're going to access also a broader scope of services. And we're going to connect that access to your normal work and life schedule. But it's also beyond access for us. And I think Matt would probably echo this, that improving access is not nearly enough. If you want to engage people in advanced primary care, you have to fundamentally change the patient experience. And Nirav, you shared some of these things. 85% of our patients wait less than 5 minutes in the waiting room. Average provider visits, 32 minutes plus, so that you can embed health coaching into those visits and focus on preventative care. And the minute you walk in the door of our health centers, you're experiencing something that's different. So many people avoid care, not just because of access, but because they've had a bad experience in a healthcare setting. Our book of business patient satisfaction rate is above 90%, 98%. So we're going to improve access. We're going to change the patient experience. And finally, we understand that we have to work with our employer partners every month to design and execute specific engagement strategies that target specific segments of their employee population. We know that we have to change people's behavior and the way they think about healthcare. This is not an open a health center and hope people show up and start taking better care of themselves. This is a open a health center and work with your partner to build strategies that drive people into the health center. And I think our model is just better built to address those strategies and those functions.
Yeah, I definitely agree, Doug. I think what we found is that it's the ability to build relationship with the health and wellness center to our staff that's been a little bit different in that independent model. I think at times we felt like when we were in the hospital-based setting, it was an exclusive urgent care. And when our folks went to it, yes, they had access, yes, it's supported, but it felt a bit more like that, where I feel like in our independent space, it's a lot more relational. One example that I'll give is when we were with our prior provider in more of a health-based setting, they tended to farm some things out. So we do an annual biometric screening. They had an outside company that came in and did that biometric screening. The data got captured, right? Everybody got the same data. But it's always interesting when somebody sits down and they're doing a blood draw, some of the things that they'll mention offhand to a healthcare provider that might not be 100% related to that. And in the old model, since it was farmed out to this independent person, they might make a note in a file. In our current, when that employee mentions something offhand, it's our medical providers from our health center who are then walking them out the door and then saying, you know, we've got some appointments next Tuesday. I think maybe we should put you on the books to come in and have a further discussion about what you were sharing with me. And that, I think, that we've found from that relational side, everybody is busy. Everybody has a lot on their plate and everybody wants to take care of themselves. But when there's that person on the other side of the relationship who's encouraging you to do it and holding you a little bit more accountable to it, we just see a very different reaction from our employees.
You know, Matt, you mentioned something, and Nirav, you did too. There's such a difference between having a primary care physician and having a relationship with a primary care physician. Those are two very different things. And so we talk about the segment of the population that A, doesn't have a primary care physician. Then there is this much larger segment of folks who have one, but don't have a relationship with that person. And so, you know, I can't think of many things that are more intimate than healthcare, right? The conversations you have to be willing to sit down and share with somebody. So personal, so intimate. And if you don't have a relationship, as a patient, you hold back, right? You don't say everything you need to say. You don't have the conversation. Our people had actual, true, deep relationships with their providers in our health center because we had the time built into visits that allowed those relationships to develop. And as a result, have the conversations that maybe weren't happening otherwise and led to people becoming more fully participating members of their own health. And again, not just coming to see somebody when they were sick, but coming to get things taken care of in advance, in advance of something bad happening. We know if you visit our health center one time, on average, you will engage, I think it's 3.4 times in a year. And that's what it takes to really focus on primary care.
So Natasha, let's pull back the curtain a little bit on hospital-based primary care. You're a veteran. And I'm sitting here thinking, well, what Doug and Matt are saying is nice, but boy, the value of like my on-site primary care being fully integrated from a tech perspective and from a clinical perspective with the hospital, with all the specialists in that hospital's network, that's a really powerful attraction. Can you talk to us about the promise of that, as well as the reality of that, and kind of what some of the incentives are that drive that integration, and how you would compare that to now your more recent experience of leading in an advanced primary care, but independent organization? What's the value of that too?
Yeah, no, I agree. And I can understand kind of conceptually, that seems wonderful, right? Everything is under one roof in a hospital system. But I think ultimately, I think a lot of us maybe have experienced this ourselves when you often see care in large hospital-based systems and you see kind of different services like labs and imaging and primary care visits and your specialty visits. Care can often feel more fragmented, right? Because I think with our model, we can provide a lot of things in-house: mental health, physical therapy, occupational health, health coaching, et cetera, in-house. So that's, in a lot of ways, care is less fragmented with us. When you're in a hospital system, you might be sent to different offices, different locations for those specific services. And so while all of it is under one roof, it's one very large roof where you're kind of sent to different places. And with large systems, you just have less opportunity to connect, less opportunity to partner on patients' care, because you might be just in different places and you don't naturally or organically see each other. You cannot organically collaborate or partner like you could in an advanced primary care center, where you literally are under one roof. You are with these people every day and you're working in partnership with one another on kind of common goals and common values on behalf of our patients. I think that's the piece around, I think, fragmentation versus continuity that could feel like it's better with a large hospital-based system, but because they're so large, it requires our patients and ourselves to often navigate and to really overcome a lot of fragmentation to be able to get to similar outcomes as a comprehensive model. I think the second part that I don't think has been mentioned yet today is around kind of referrals. And when you're in a large hospital-based system, when you're in a hospital-based primary care center that I've been in multiple roles previously, you are often incentivized in many ways to refer within your hospital for all of those services, which makes sense, right? You're all one system. But what that often means, though, is that hospital-based labs, imaging services, specialty referrals, there's often higher cost related to using those hospital-based services. And that's due to a lot of different factors, including hospital-based facility fees and overhead cost and certain billing codes that you can use in hospitals. So at the end of the day, what that means is that often our hospital-based primary care providers are incentivized to refer to high-cost services for care, and it is in their incentive. When I was a primary care provider in a hospital-based system, often when we were shown metrics about how we were successful because we were the primary referral base for our services within. There was not necessarily a value put on primary care. The value was to feed all of those more lucrative services for the hospital system. And so in that way, there is this kind of inherent incentive to driving referrals to high cost services within, which drives value for the hospital system from a profit perspective, but often that is at the cost of the value for our patients and for our clients. Our model, though, operates a bit differently in terms of referrals. It is in our best interest that our patients actually are referred to services that are considered high quality and low cost. And that's sometimes not part of hospital systems. It's often community-based providers where those services are able to be provided at a lower cost, but with just as high quality. In our model, we do have a pretty sophisticated referral approach where our model is very data-driven. We have access to Garner data, which is a database of specialty data and imaging and health center lab data across the country, which helps us identify those specialists and those referrals who are considered to be highest quality, best patient experience, and low cost options for our patients. And so when our referral team ends up receiving a referral for a patient, we help patients kind of navigate the high quality, low cost options for them based off of this data. And once we kind of help identify a provider of choice or an imaging center of choice, we help them navigate in terms of helping to schedule appointments for them, helping them get to those appointments, and then after the appointments, ensuring that their referrals kind of were closed and that the recommendations were fed back to the primary team. And what that means at the end of the day is from a cost perspective, we're able to refer to these really high quality, low cost alternatives for patients that at the end of the day, they have better experience and lower costs for our clients. We're not incentivized to refer to high cost options on our end.
Yeah, I'll take that just a step further in terms of what we see in our data. Just the benefit of having 32 minutes per appointment, as Doug said, versus the standard of 11 minutes in traditional primary care, is that we see automatically, as soon as you turn on something like this, a 25% reduction in referrals out to specialists, because you've now empowered that primary care provider to do more of what's in his or her toolkit. It's just that maybe in a different model, they didn't have the time to exercise that. In addition, when you add in peer-to-peer consults, something we call e-consults, you continue to see that specialty referral rate go down. And then, as Natasha mentioned, when you provide a really white glove service to get patients to and from the right specialist that our data tells us is the highest value provider, independent of what network they happen to be in, as long as they do align to your insurance network, we see the overall spend go down. And in a recent analysis we did of almost about 225,000 members who are under this advanced primary care model through us, we saw an overall 10% reduction in the actual specialty spend. What was really interesting is that we saw lower frequency of people going out to specialists, but when they did, it was actually higher claims on average. And yet that might sound paradoxical, but what it means is when you increase the engagement in primary care and you kind of open that front door wider and you give them enough time to sort of marinate in the primary care broth, you're going to take away a lot of the unnecessary specialty referrals. And when you do send them out, it is for the right reasons that require sort of that advanced training that a specialist has, as opposed to just sending every old headache to a neurologist, or every old rash to a dermatologist, or every old bellyache to a gastroenterologist. And so that really tells us that, you invest more in primary care, you will see the downstream benefit for your patient experience. They're not waiting all that time to get in, as well as on cost. But what I'm excited to do next is actually kind of the question and answer board is popping. It's the biggest party in town right now. So I want to make sure we save time to address the thoughtful questions that are coming in. So again, a reminder to everyone, the Q&A function that you see at the bottom of your Zoom screen, any question that you have right now, just go ahead and pop it in, and we'll try to get to as many as we can today. First one from Cameron. Is advanced primary care the same or similar to comprehensive primary care? Anyone want to take that one?
I can start.
Provider
Go ahead.
this question,
Yeah, I can start. Yeah, it's a good question because I think we probably use it synonymously. I don't think we have official definitions of comprehensive and advanced, and I probably use them kind of interchangeably. But I think at the end of the day, what that means is providing as much as we can under one roof safely. Our data show that we can actually meet 90% of patients' healthcare needs through our advanced primary care model. I think just perhaps it's clearer if I just even describe like what is in our advanced primary care model. So that includes kind of our traditional primary care services, including acute care, preventive care, chronic disease management. Also includes on-site medications and labs. Also includes kind of after-hour services, including after-hour nurse and provider triage. And then Nirav had mentioned our e-consults, which is kind of a specialty e-consult model where our primary care providers can consult with specialists across the country for questions about patients, which ultimately ends up avoiding specialty referrals, as Nirav mentioned, also included in kind of our advanced kind of core model. So again, trying to create a suite of services in our advanced primary care model that really then kind of keeps care in-house as much as we can.
And I think keeping that care in-house builds confidence in the patients that our providers see. They're so accustomed to this reliance on urgent care opportunities and hearing so many different voices about the same concern. I hear this from one person, I hear this from another. When you build a relationship with a provider and you can have so many of your health needs and questions handled in one place, it builds confidence in the care plan and compliance with that care plan as well.
Thank you. Maybe Doug, you can take this next one from Stacy. This model deals primarily with on-site or near-site care, right? Is there an employer size threshold that this is applicable to? Like, what if we have too few employees at a site? How does that work?
So I think the great thing is that there are options. And while we do believe there is a threshold for where having your own independent on-site health center makes sense, and I think we often talk about 1,000 lives as being kind of that position, there are options that allow you to be part of a shared health center access point that allow organizations with 100 lives to be covered in a model like this. So I think the best thing is to contact and explore options and help us determine which one is best tailored for your needs and your organization size, I'm sorry.
Just to take that further, are there models where you don't have to go and build a whole health center, where you can kind of just tap into something that's already out there?
Absolutely. We have a highly robust virtual platform. Maybe Natasha would tell you more about that, but I think here's the one statement I would make about our virtual offering is that I know Teladoc has become a very popular option in a lot of organizations, and I think there's good work being done there. But the thing that's great about our virtual option is that it allows for continuity of care. You can establish a relationship with a specific provider and not just be at the mercy of whoever's on call or on duty at this particular time. I would also say that the service and the appointments that are held virtually within our system mirror the same process that we follow in person, that it is still embedded with health coaching, that we're still talking about preventative care, and it's still a very true advanced primary care model. It's just being managed in a virtual setting.
And how about options like to share in the physical world if you didn't want to go virtual?
So we have, go ahead, Natasha, please.
Oh, you're good.
No,
Okay.
please.
We also have our network options as well. And so what networks are, they're in concentrated markets where we have a critical mass of employers. There are a number of employers who actually share health center access. And so we have, just to give you some examples, we have markets in Indianapolis, Cincinnati, Columbus, Orlando, Las Vegas, et cetera, et cetera, et cetera. I think 78 or so centers in these markets. But in essence, if you were potentially a smaller employer who had access to these network markets, your employees, spouses, dependents could have access to any of these centers, which on average in many of these cities, we have maybe 5 to 8 centers, which then increases that convenience, increases kind of the proximity and opportunity for employees as well as spouses and dependents to be able to access these centers. Often these centers have primary care, and many of them include mental health, physical therapy, health coaching, et cetera. And so by joining these networks, you have access to all of these services where it might not make sense to invest in all of these things if you're a smaller employer for the smaller population. But by sharing those resources and sharing that access with others, you're able to actually provide a pretty robust offering to your population.
Great. Matt, I'm curious, you mentioned focusing on your employees, I assume mostly teachers and administrative staff, but how did you make sure the employees' dependents or the dependents as well as spouses were able to get access to? Did you employ any creative strategies there?
Yeah, we've been really, really lucky to be in a space, as Natasha was talking about, that has that ability to do that kind of blended model. So we do have our on-site health center, but then we in Indianapolis do have a circuit of network clinics that really ring the city. And I would say right now, based on our last, I think about 40% of our visits are at those network health centers. And often that is your dependents, that is your spouses, because we have folks who come to us from all over the city. So it may be more convenient to visit a center near home. We've also had dependents who are still on our insurance who are doing visits at Marathon locations that are outside the Indianapolis area or doing virtual visits. And we've heard really positive feedback relative to that. They love the boxes that they get that have their scale and the other things so they can take their own vitals and do all that stuff. So no, it has really, that blended has allowed us to meet so many people where they are regardless. And I will say it is filling a huge hole for us on the mental health side, because I don't know if Indy is unique in this, but there are just not enough providers available within the immediate area to meet our staff and their dependents and their spouses. And so we have seen a huge pickup of folks using that virtual mental health option or going to the network clinic. We had explored attempting to have some mental health services provided at our on-site, and the volume for that wasn't necessarily there, the timing for that, but then folks being able to access it through those network centers and virtual has been a huge, huge impact for us.
Think about mental health. The impact on the individual is clear, something we all understand. But I think sometimes what we don't think about is how mental health needs impact the overall organization, from how cooperative people, how collaborative people are, how patient and creative people are in their day-to-day dealings. Imagine that you've been struggling with depression or anxiety or something else for years, and you finally decide, I'm going to do something about it. I'm finally going to seek the care I need. And you call a provider's office and they say, hey, we can see you in 8 weeks. It's incredibly deflating. And this is something we heard over and over again from our people. I finally decided I was going to do it. I have the courage to call, and they say, hey, we can see you in about 2 months. And I'm done. I'm out. It's almost a signal to that individual that I'm not going to even pursue it. This model, our health center, allowed people to get in within a week to finally strike on that chord that I'm ready to do something about this. And so you think about the impact of not just physical health, but mental health on an individual's life and their performance and things like that. It's not just seeking and getting help, it's getting it in a timely manner. And right now, that is so hard to do in the traditional model.
Yes, it is unfortunate what's happening out there. Let's go ahead and ask another poll question. So if we can go ahead and pop that up. And please go ahead and take a moment to answer this question. All right, let's go ahead and see what the responses are. All right, so the majority of folks have employees, dependents, beneficiaries in general, pretty dispersed. So, Matt, it sounds like what you described, which is a blended model, you want something really close, something you can really control and align to the needs of that core population, but then also having access to shared centers that you don't have to build, but you get to just participate in the sort of shared access to it, where you get all the same benefits, but with much lower cost is something that would be of interest to this group as well. I'm going to go ahead and go to probably what's going to be my favorite question of the day. ROI. Patrick asks, minimum employer size to make this a viable model. What is the typical time range for the model to show a positive ROI? Is it 1? Is it 3? Is it 5 years? I could talk all day about this, but I'm curious if anyone on the panel wants to start.
I would share my personal experience. When we opened our health center, we were prompted to believe that we would see a favorable financial ROI within 3 years. And things took off so well that we were slightly above a 1-to-1 ROI in our first year. And that's not typical. We were an education system, obviously, and I think what we have found is that educators tend to navigate a little more slowly to the model, but once they experience it, the momentum builds and engagement grows very rapidly. So for us, it was quick because, again, I think the focus was engaging people into the process and helping change those behaviors. But I would say, as I think about our book of business specific to the education environment, we are seeing favorable ROIs typically beginning in year 2, many in year 1, and nearly everyone in year 3. Now, that, of course, hinges on a few important factors, engagement being the most significant. And so with engagement becomes this need to have a healthy relationship between the level of engagement and the opportunity for provider capacity. Those two things have to be in tight alignment. At some point, high engagement challenges provider capacity. So we have to make sure that we're staffing a health center in the way that people have access when they need it. It's part of the magic behind our health centers is the opportunity for same day and next day appointments. But to maintain that philosophy of care, you have to have a provider capacity level that allows for it. And so again, you have to watch those two measurements closely, but as long as you do and you're practicing those engagement strategies, the ROI is the natural result.
I'll share some data that's kind of maybe hot off the presses. I'm not sure. Looking at Nirav if I don't want to overspeak, but we have done some really cool analyses recently on ROI estimates, and it's such a good question when you start seeing it early. And Doug mentioned some clients we see it early. There was in this one analysis about 89,000 lives that were analyzed, and on average, that ROI for clients across the board was for that first year about 1.2. But that ROI increases all the way to year 5 to be about 3.7 times ROI. So really kind of impressive early data around kind of early ROI. But again, the more time that we have to work with patients and the more engagement we have over time, that number can exponentially increase.
Yeah, I'll just say a couple of things to this one. The first is define what return means to you. For what you've heard so far is we're talking about return on your health plan spend. If you spend X dollars PM on advanced primary care, what are the Y dollars per year you get back in terms of beating trend? But I encourage you all to think a little bit more about ROI, maybe pull in some of the themes we talked about earlier. So for example, does this help you attract the right talent? Hard to measure, but over time, you'll start to figure out as more and more employees tell you what a valuable benefit this is. Does it help you retain them? We talked about productivity. There's also really ample data if you choose to engage on the occupational health side and add that service in terms of reducing your injury rates, reducing your recordable rates, reducing your overall claim spend. So your health and safety people are also happy with you. And on both sides of that ledger, you can draw a bigger sort of perspective with regards to ROI. But just to sort of drive home some of the points Natasha started to make on really large analyses that I can guarantee you we're not cherry picking. We just took all the data we had over 5 years and said, what happens when you turn on this service? And let me tell you, we're talking about advanced primary care just broadly, not specifically exactly what we did here or what a competitor did, but just want to sensitize you to the benefit is you essentially flatten trend. So you start this in the first year when you add your advanced primary care fees and you take your health plan spend and you mosh them together, you actually beat your market trend. About 65% of the people our clients did in that first year, 35%, the rest got it to it in second year. But that trend, if you continue to flatten it when you compare it to the 7 to 9% renewals that you all are seeing typically across the country, that what Natasha said, that the compounding effects of flattening your trend really start to pay off in the out years. And so we are seeing most of our folks get to positive ROI in year 1, nearly all in year 2. And the times when they don't, just to tell you, it's never perfect, but the times when we don't get to positive ROI, number 1, if you overbuild at the start, like you build the world's fanciest health center with 25 exam rooms and 10 mental health folks and no one's using it, don't do that if you're going to go down this route. Keep it lean at the start and then kind of grow into it as your engagement grows, as you start to see that ROI and you decide to invest those savings back into your model. We also don't see savings initially with populations that have very, very low spend at the start. So either they're super well managed or they're just non-utilizers of healthcare. And then they start engaging in healthcare, and good providers like Natasha are like, well, you need a colonoscopy, and you need a mammogram, and you do need to see that cardiologist for that chest pain, and you're actually adding good spend to what was very low, and as a result, in that first year, you may not also see. So these are just a couple of things to think through, and if you want to talk more about it, we'd love to share that white paper with you that Natasha was referencing, as well as just have a live conversation anytime. Let's go on to a few more questions. Let's see. Diane is asking, Natasha, this one's for you. We're huge advocates for this. Key success is having the right provider for your population. How do you get the right providers to join Marathon Health?
Sure. Yeah, I think Doug and Matt, you put it well. Success means having the right people, right? And keeping the right people. And that is a concept that we very much prioritize and emphasize in Marathon Health. The success of our model is our people. And it is critical that we recruit the right people and that we retain the right people. And so just to kind of walk through a little bit of that with you, recruitment wise, we're very, very intentional about recruiting providers and clinical teammates who are aligned philosophically with our model of advanced or comprehensive primary care. We do rigorous clinical screens on especially our provider applicants, but then also kind of behavioral screens as well. We want to ensure that we are recruiting folks who excel at shared decision-making, motivational interviewing. Doug mentioned health coaching is such a critical and core part of our philosophy. We intentionally recruit folks who really are aligned with that. Where healthcare is not just like prescribing some pills and see you in a year. It really is building relationships and understanding the values and the goals of our patients so we can be part of their healthcare team and have the honor of working with them on their healthcare. So recruitment is one piece, and we're really intentional, understanding some areas are easier to recruit in and others. We have an amazing talent acquisition and recruiting team who work very hard to be creative in terms of just finding the right pool of applicants for us to interview. But again, interviewing is very much about like, are you aligned with our philosophy? Are you clinically excellent? And can you provide amazing, excellent care? Because we need that. And our patients and our customers and our clients, that's our commitment to you, right? Is to deliver on that. In terms of retention, I think the piece that one of the data points I am so proud of as a provider is we have over 90% provider retention in our organization. My clinic that I left 2 years ago, we had a 50% retention in a year. We had 6 providers and 3 left. And that's not foreign in primary care. There's a lot of burnout. There's a lot of turnover. There's a lot of challenge right now with recruiting, retaining talent in primary care. That is so different with our model. And I think in terms of the kind of greater than 90% retention rate, so much of that is, I think, that value of building relationships with our patients. When I talk to providers across the country, what they tell me like the most as a leader, I always think like, okay, I'm gonna hear the negatives first. What I hear the most is, this is why I went into primary care. And this is why I'm staying. Like, I love my job. And sometimes there's the little things of, okay, I want you to fix X, Y, or Z things. But for the most part, people love our model and they want to live in this model for the rest of their kind of professional lives, which is just so valuable to hear as a It's really the model, it's the support that we provide, and really kind of the services. And I think the resources that we're able to provide for folks to provide great care to their patients.
To add just a little something,
Yep,
I'm sorry, is that we also work very closely with our partners on making sure that all the qualities and qualifications that Natasha just mentioned are also in tight alignment with the culture of the organization they're going to serve. And I'll use educators as a specific example, is that no one knows service to others more so than teachers do, right? Teachers know, custodians know, buildings, facilities, maintenance and grounds, paraprofessionals, building secretary, they know what service looks like. And so when we're hiring a team, and that's what we do, we hire a team. We don't hire 5 individuals. We hire 5 individuals who are qualified, work well together, and understand the population they're about to serve. Because if I have a 4th grade teacher walk into the health center and they're not greeted in a certain way at the front desk, they're done. And they're not just done, they're going to go back and tell everyone in their hallway, everyone in their building, that was not the experience they were promised. Those things cannot be overcome. So not only are we hiring incredibly qualified folks, but we're hiring folks who understand the population that they're going to provide service to and embrace that as a part of their service that they provide every day in the health center. And those are difference-making behaviors.
And I would say
Thanks,
from
Doug.
a practical standpoint, I've been involved in the hiring of every person who works in our health center here. I am part of that interview process, and that's an important aspect for us.
Thank you to both. And to just sneak in Amy's question on APPs or physicians, what is the model? We do both. And oftentimes the clients are the ones who are telling us which they prefer. But we could talk more about that. Well, wow, time has flown. We are at the end of our journey together. Want to thank the panel for just the free-flowing conversation and the really brilliant additions that you made to our dialogue. I want to thank the audience for these wonderful questions, which we will go ahead and download and answer and then circulate after this webinar so that if we didn't get to yours today, we'll certainly get it to you in writing. We'll also distribute the some of the collateral that we described earlier, a little bit on Marathon Health, as well as a white paper on ROI that you might find interesting. And with that, thank you. Good day to everyone. Hope you have a great rest of the day and a great weekend. Go Cavs. I'm a Clevelander, so go Cavs. Thanks
Watch
very much, everyone.
it.
Thank you, everybody.
Sorry, Matt. Had to work that in at the end.
I figured.
Thank you.